Good afternoon. Welcome to the Neuro-Ophthalmology IC, Neuro-Ophthalmology made easy. Here we will be discussing about the common neuro-ophthalmological problems which we encounter in our daily day-to-day practice. Okay. To start with, I will be speaking on swollen disc with normal vision.
Dr. Kalaimathi is a senior consultant working with Giridhar Eye Hospital, Cochin, and her special interest is in neuro-ophthalmology and glaucoma, and her topic is swollen disc with normal vision.
Good afternoon. Many times we encounter with patients with swollen eyes, both eye with normal vision. So how to deal with them, and why is bilateral disc swelling important, and what are the causes for it? Is it a true swelling or a pseudo swelling? These are the, we'll be dealing with these questions in this talk. Optic nerve meninges is continuous with the brain meninges, so any increase in intracranial pressure will be transmitted onto the optic nerve head and causing disc swelling. Two terminologies are important. Papilledema is disc edema secondary to increased intracranial pressure, and all other acquired edematous disc is disc edema. Disc edema is important because it causes ischemia of the optic nerve, which eventually causes visual impairment. And papilledema has a diagnostic as well as therapeutic potential. Now coming to a 22-year-old girl who presented with headache, and vision was 6/6 and 6 both eyes, and left eye showed an elevated disc and vessels were normal. So to begin with, we did a simple test FAF that picked up the buried drusen. So to confirm this, we went ahead and did the B scan. The B scan showed the optic nerve head drusen as shown in the arrow. So when we do a B scan for drusen, we have to always, when we do a B scan for drusen, we have to always look for the A scan spike here, which is diagnostic of drusen. So how will you differentiate papilledema and drusen in B scan? In papilledema, we have this crescent sign. That is, the CSF collection is here, so we get this crescent sign. But in drusen, it will not be there. This is a 60-year-old woman who came for a routine checkup. Again, left optic disc elevation, and we did the simple test OCT, which showed lumpy, bumpy appearance. So how will you now differentiate optic disc drusen in OCT? In OCT, as shown here, there will be a hyper-reflective ovoid space in which is drusen, and here a hypo-reflective triangular space will be there, which is diagnostic of papilledema. And RPE Brooks membrane will be straight in case of drusen, as you can see from here, and in case of papilledema, it will be pushed towards the vitreous. Drusen can also be made out from CT scan, but usually we don't do that. So look at this disc. Bilateral disc margins are bilateral, the disc margins are blurred. This is a 5-year-old child who came for a routine checkup, and the refraction showed +6 diopters in both eyes. So this is a hypermetropic disc. And look at these congenital conditions, the myelinated nerve fibers, hyaloid remnants, etc. These things we can find out on ordinary examination. So a pseudo disc edema is often seen in a routine examination in an asymptomatic patient with marked hypermetropia or myopic astigmatism, and past medical record should be looked for. And now look at this picture and this one. And look at this. There is a spot over here. When we see this yellow spot, it is suggestive of a disc drusen. That means it is pseudo disc edema. When we see this, there is a blurring of disc margins, disc hemorrhage, and obscuration of vessels, dilatation of surface capillaries. These things are suggestive of true disc edema. So, blurred margins, flame-shaped hemorrhages, disc vessel obscuration, dilated retinal veins, and disc hyperemia, all these are point out towards true disc edema. So, in true disc edema, patients present with headaches with or without nausea and vomiting, with a new type of headache, which is worse in morning, worse on coughing and straining, with transient obscuration of vision, pulsatile tinnitus, with horizontal, sometimes with horizontal diplopia. Vision may or may not be reduced. So, coming to papilledema, this is disc edema due to raised intracranial pressure. The three main conditions which give rise to papilledema are space occupying lesions, dural venous sinus thrombosis, and pseudotumor cerebrae. This is a 67-year-old gentleman who came to us with headache, vomiting, and left-sided weakness, 1 week duration. This is the fundus picture, bilateral disc edema. So we imaged him. The image shows a right-sided mass lesion with surrounding edema, and this disc edema is because of this surrounding edema. So this is the disc edema is because of this space occupying lesion. This is the post-contrast picture. And this is a 28-year-old obese lady with polycystic ovarian syndrome with a recent onset headache and nausea, and again bilateral disc edema. We again imaged her, and there was lateral transverse sinus thrombosis. MRV was done, no flow in the lateral sinus in the right side, and so this disc edema was due to lateral sinus thrombosis. The dural venous sinus thrombosis can occur at any age, male or female, mostly after infectious mastoiditis, sometimes after dehydration. It can occur in pregnancy, etc. This is a 35-year-old lady, classically presented with throbbing headache, unremitting, and was accompanied by nausea. She had occasional tinnitus, vision 6/9 So bilateral florid disc edema. This is the HFA picture, bilateral constriction of the fields. And MRI showed tortuous optic nerve and partial empty cella and enlarged optic nerve sheath, suggestive of idiopathic intracranial hypertension. So the disc edema in this particular patient is because of idiopathic intracranial hypertension. So he was sent to neurosurgeon. He did a VP shunt, and this is the picture post shunt surgery picture. The papilledema reduced markedly, and this was the HFA picture post surgery. So if we intervene at the appropriate time, we can say salvage the vision of the patient. So apart from bilateral papilledema, what malignant hypertension is very important. The other things we should have in mind are diabetic papillopathy, infectious conditions like optic nerve sheath perineuritis because of tuberculosis, syphilis, uremic optic neuropathy, hypocalcemia, etc. This is a patient, 43-year-old man who came to us with severe headache. He had 2 episodes of bilateral disc edema, recurrent disc edema. When BP was checked, it was 220/120. So this is a case of malignant hypertension. So if you don't get any cause of bilateral disc edema, we have to think about drugs causing it. Vitamin A, tetracyclines, steroids, NSAIDs, cyclosporin, OCP, obstructive sleep apnea, these things should be kept in mind. So follow-up should be with perimetry every year, and assessment of ganglion cell by OCT should be done every year. So to conclude, bilateral disc swelling is a medical emergency. Imaging is crucial for the diagnosis. Persistent disc edema causes permanent damage to the optic nerve. So prompt diagnosis and timely intervention is crucial in salvaging the vision and life of the patient. Thank you.
It was a nice presentation. Thank you, Dr. Kalai.
Next is a talk on swollen disc with blurred vision. It was supposed to be dealt by Dr. Nina, but due to some personal emergencies, she had to leave. So Dr. Thomas Arun Verghese will be talking on the same subject. He is a senior consultant, Alfonsa Eye Hospital, Todupuzha. He did his glaucoma fellowship from UK, and he has special interest in neuro-ophthalmology. Over to you, Dr. Arun.
Thank you. I'd like to thank AIOS for this opportunity. My topic is swollen disc with blurred vision. Dr. Kalai's talk has made my work quite easy. These are a few cases I've seen over the last 22 years, and you can see the appearance of the swollen disc can be very variable, and equally the etiology as well was extremely variable, as you can see here. So how do you go about finding out and narrowing down the possible cause of the disc edema? So this is my consultant, Mr. Barr, who I used to work with in UK. This was his list. This can be used for any medical condition. So this is the list he used: inherited, neoplastic, vascular, inflammation, infection, immunological, toxic, endocrine, degenerative, and of course in an unusual case, in this case, hypotony. So these are different possible etiologies that can cause the disc edema. And if you see the pictures I showed you earlier, so you can see here, you got inherited, inflammation, infection, vascular, neoplastic. So all the different etiologies are listed here, degenerative. So all the different etiologies can present to us, and we need to narrow them down. Of course, you can have a disc with normal looking disc with a reduced function. It's an optic neuropathy, and Dr. Kalai has just covered papilledema in detail. So in one case, one situation, you have normal appearance with reduced function. Here, abnormal appearance but normal function. But here we're dealing with abnormal appearance and abnormal function. So approach is just like any case, history has a great role, and examination and investigations. Pseudo disc edema, Dr. Kalai has already covered. Make sure it's a true disc edema. So this is a rare set of photographs, 2008, 2015. This patient had a photograph because of a suspected RNFL defect, but she came 7 years later with the disc edema, and you can see all the different changes: the color, the cup, the contour, the circulation, and the surrounding retina. All the changes in the appearance you can see here. So examine the disc with the 5 C's and differentiate true versus pseudo. The most useful I found as the cup and the vessels. The vessels are seen very clearly over the disc in pseudo edema. And then, of course, whether it's unilateral or bilateral, because the etiologies can be quite different. Unilateral, you're thinking something like posterior scleritis, optic neuritis. Of course, any of these conditions, if they left over time, they can become bilateral. Bilateral presentation, you think of papilledema, systemic causes, systemic drugs, and important role of the history. So you just mentioned, you asked for the sudden onset of blurring. With pain, you think of inflammation, but if it's painless, you think of vascular. Gradual, you think of a compressive lesion. And of course, other things like numbness, suggestive of demyelination, history of malignancy, drugs, coagulative disorders, all these are extremely important, not in our usual ophthalmology case. This is a patient I saw while in the UK, and her only complaint was she cannot see this rim and this rim of her glasses. How observant she was. And when I checked the fundus, this was the appearance. So this was an AION affecting the inferior and nasal part of the disc, causing the corresponding field defect. And then on asking history, she had all the features of jaw claudication, polymyalgia rheumatica, she had ESR, which is very high, and the positive temporal artery biopsy. So the history is very suggestive that it's a vascular cause. Of course, examination as well, the checklist of examination, do a brief neurological examination as well as a routine ophthalmology examination, all the tests of the optic nerve function. Blood pressure, please don't forget. And this is a case Dr. Kalai has actually shown. This is a case of the lumpy, bumpy appearance, suspected papilledema. And sometimes if you have access to, most of us have access to a fundus photograph, you can just put the camera on the fluorescein angiogram setting and take a photograph, and you see the autofluorescence of the optic disc, drusen. And if you're really doubtful, you can either do a B scan or CT scan, or in this case an FFA was done, and you can see the disc is staining beautifully but not leaking. Moving on to true disc edema. So this is a case of a patient again I saw in the UK, blurring of left eye for 3 weeks, and you can see there's a marked disc edema. Right disc is absolutely normal, and just before I put the patient on the slit lamp, I noticed this fullness in the temporal fossa, and so I suspected a bony lesion, and a CT scan showed a fibrous dysplasia. So I just want to highlight that nowadays, with the increasing use of slit lamp, sometimes we put the patient straight on the slit lamp, and subtle findings like this can be missed, which will save you a lot of trouble. Investigation, the blood investigation you need to do, of course immunological tests as well, and appropriate imaging, MRI, and bony cases suspected, then you think CT is probably better, and then of course in some situation you need to do liaise with the neurologist for an LP. So again, a patient 47-year-old, slightly on the higher age group, and presenting with blurring left eye. You can see the disc margin is blurred, so all features suggestive of an optic neuritis with decreased optic nerve function. But important to understand is that if this is typical, they should behave in a particular pattern. They usually worsen for 2 weeks and start improving by 4 weeks. You can see exactly by 2 weeks she has started improving. So typical optic neuritis should behave in a particular pattern, otherwise you should think of atypical optic neuritis. We heard a beautiful talk earlier. Again, a 41-year-old carpenter, blurring of vision left eye, history of cat scratch about 2 months ago. You can see the disc edema and also the associated edema of the adjoining retina. So this is a Neuro Retinitis, and had a very good response with systemic antibiotics and systemic steroid treatment. Of course, if your findings are beyond the disc, so you mark cortical spots extending everywhere, then you think of a systemic cause. Again, Dr. Kalai showed it. So this is a patient with a blood pressure of 210 by 130. Again, always examine both eyes. The patient with complaining of blurring in the left eye, left disc edema, and the other eye was a pale disc. So this is a case of, this is a Foster-Kennedy syndrome, or pseudo Foster-Kennedy syndrome. You can only differentiate by doing an MRI. So this was actually an AION which presented. So always examine both eyes. Even though the complaint is one eye, always examine both eyes, and then that will help you in narrowing your diagnosis. Again, a patient I showed you earlier with the disc edema. So when she came in 2015, I made a diagnosis of posterior scleritis. She responded very well to systemic steroids. At that point in time, I actually did not examine the other eye, and she came in 2019 with a blurring in the left eye, and she had an X-ray to retinal detachment. And you can see now, in 2019, appearance of the right eye, and it has become a sunset fundus. So you can see over a few years, the diagnosis revealed itself. It was a case of VKH, which there might have been findings in the left eye at initial presentation, which I did miss because I did not examine the left eye. So always examine both eyes, and that will help you narrow your diagnosis. 16-year-old girl, 11th standard student, present with some complaint of headache, and when examined, she had features of panuveitis, and you can see serum A's was extremely high, Manto was normal, and then we made associated with the physician, we made the diagnosis of sarcoidosis, and we started systemic steroids. We did not actually get a tissue diagnosis because they were reluctant for a biopsy, and they also did not do a CT thorax, but all the blood tests were done, and MRI was also done to rule out any mass. And then we started on systemic steroids, probably a little reluctantly, and then on treatment, she developed hemorrhages, which showed, and also she developed a facial palsy. So, but fortunately, we were able to tie all together with the clinical diagnosis of sarcoidosis. We had features of ocular sarcoidosis, the disc edema, and all the features of panuveitis, and now she had features of neurosarcoidosis, the facial nerve being the commonest nerve involved in facial nerve, and the optic nerve are the commonest nerves involved in sarcoidosis. So she had new vessels on the disc. We actually increased the steroids. We actually gave her a PRP as well, and she had a very good response. You can see the initial appearance, and now how she looks. And last patient, again, Dr. Kalai has covered this. This is a patient with bilateral disc edema, and as she said, venous sinus thrombosis. One risk factor, of course, is dehydration, and this patient was also on oral contraceptive pill. So the two risk factors for possible thrombosis, dehydration and OCP, and she came with double vision and blurring, and that is because of the sixth nerve palsy. And all cases of papilledema, you have to do an MR venography. So you can see the MRI here. The superior sagittal sinus is thrombosed, and fortunately with appropriate treatment, the recanalization happened, and you can see the flow after the recanalization has improved significantly. So in summary, take-home message is do a detailed history and drugs, history of malignancy, some things we miss in routine ophthalmology cases, focused examination, true versus pseudoedema, unilateral versus bilateral, blood pressure, don't forget, general and neurological examination, and do the appropriate investigations, blood and imaging. Thank you.
Thank you, Dr. Thomas Arun. That was a lucid presentation. Next, I call upon Dr. Anne J.K. to speak on the pale optic disc. Dr. Anne is a senior consultant in the Department of Neuro-Ophthalmology and Oculoplasty in Little Flower Hospital, Angamali, Kerala. Over to you, Anne.
I would like to thank Dr. Kalaimathi and AIOS for including me in this IC. My topic is pale disc. Optic atrophy is not a disease. It is a non-specific morphologic endpoint of any disease that causes damage to the ganglion cells or axons of the optic nerve. Site of insult, it can be either within the eye, that is ganglion cells, retina nerve fiber layer, or the optic disc, or any parts of the optic nerve or intracranial such as chiasm, optic tract, or lateral geniculate body. Before going into abnormal disc, we should know about normal disc. Normal disc is composed of axons of ganglion cells, blood capillaries, astrocytes, and connective tissue. When the light passes through these ganglion cells, it is reflected by the blood capillaries, which gives the optic disc a pink color. Normally, 10 to 12 blood vessels are seen on the surface of the disc. Optic atrophy can be classified ophthalmoscopically as primary, secondary, consecutive, and cavernous. In primary optic atrophy, this is not preceded by disc edema. There is degeneration of the ganglion cells, which is accompanied by proliferation of the glial tissue in a structurally orderly manner, so there is no structural alteration. Disc appears flat, pale, with clearly demarcated margins with normal retinal vessels, usually seen in compressive lesions. In secondary optic atrophy, it is preceded by disc edema, and after degeneration of the ganglion cells, there is excessive proliferation of the ganglion tissue, and there will be an alteration in the structure, which gives a dirty white-gray appearance to the disc with poorly delineated margins. Consecutive optic atrophy is following the disease of retinal vasculature, ganglion cells, and choroid. Classical description is waxy pallor of the disc with normal margins and normal cup size. Attenuation of arteries are seen in conditions of retinitis pigmentosa, choroiditis, pan-retinal photocoagulations, etc. In cavernous optic atrophy, there is axonal degeneration, but there is no proliferation of the glial tissue, which gives a large cup. There will be notching of the neuroretinal rim, nerve fiber layer defect, and vascular changes seen in glaucoma and methyl alcohol poisoning. Apart from total disc pallor, there are conditions which affect a part of the disc. Most commonly seen is temporal pallor, which affects the papillomacular bundle. This condition is seen in toxic or nutritional optic neuropathies, which commonly affects metabolically active papillomacular fibers. Superior and inferior disc pallor is seen in ischemic etiology, which is explained by the blood supply to the optic nerve. Bow tie atrophy is seen when the nasal crossing fibers are affected. So the fibers coming to the nasal and temporal margins of the disc is affected, which gives a pallor in the shape of a bow tie. It is seen in chiasmal lesions. There is an etiological classification also, hereditary, vascular, toxic, and so on. So I'll give you some examples. A 62-year-old male came with sudden onset of vision of right eye of 1 week duration. Best corrected vision was both eye 6/6, and he had right eye RAPD. He was a diabetic and hypertensive. This was the fundus picture. We can see a segmental pallor of the disc, and on visual field there was a corresponding inferior field defect, and this was a case of ischemic optic neuropathy. Another patient, a 24-year-old male with defective vision in right eye for the 3 months history after a history of head injury. Vision in right eye was 636, left eye 66. Right eye RAPD was there, and fundus showed optic atrophy in his right eye and reduced field. And VEP showed ill-defined waveforms, and this is a case of traumatic optic neuropathy. Another case, a 50-year-old male with defective vision, both eyes. Few months he was complaining of defective vision. Best corrected vision was 612. Pupils were normal. Fundus was also looking apparently normal. And visual field showed there is a centrocecal scotoma in his right eye and a slightly enlarged blind spot in his left eye. And OCT confirmed thinning of the retinal nerve fiber layers. History taking revealed that he was a chronic smoker and alcoholic, and this is a case of toxic optic neuropathy. Another girl, 22-year-old female, defective vision in right eye more than left eye for many years, 3 to 4 years. Vision in right eye was profound loss of vision, hand movements only. In left eye 636 with right eye RAPD. Primary optic atrophy in both eyes. And we could do only vision in left eye because right eye vision was so poor. And we could see a vertical field defect. And on imaging, we could see a pituitary tumor. So this is a case of compressive optic neuropathy. Another patient with defective vision in right eye with limitation of extraocular movements. Right eye vision was hand movements and left eye was 6/6 with RAPD in right eye. So the fundus was pale disc, and we did an imaging also because he had movement restriction, and we could see a mass in the optic nerve at the orbital apex encompassing the optic nerve and surrounding structures. On slit lamp examination showed lesion nodules, and he also had cutaneous lesions. So this is a case of neurofibromatosis, optic nerve glioma. This is pale disc after pan-retinal photocoagulation, a case of consecutive optic neuropathy. And another pale disc, the surrounding retina shows the features of retinitis pigmentosa. So it is important to see the whole retina in case of pale disc. So though it may look bit confusing, but with proper history taking and clinical examination, we can get a clue about the diagnosis. Like in time of onset, if it is an acute, more likely inflammatory or traumatic causes. But if it is slow over months, it can be compressive, toxic, or nutritional. And in elderly age groups, ischemic optic neuropathies are seen. And always look for other cranial nerves or systemic neurological involvement. And also take a history so that you can know about any ocular and systemic diseases coexisting. And some optic neuropathies run in family, so family history is also important. Also exposure to drugs, toxins, and all. So do a complete optic nerve function test, because sometimes even if the patient has 6/6 vision, visual field or color vision may get affected, so that otherwise you may miss the diagnosis. FFA, OCT, and VEP, we are not using this routinely, but in some cases this may help in the diagnosis. So apart from the routine blood investigations, if you are suspecting a tumor, demyelination, or fracture, we do imaging and tests. If you suspect a specific disease, the test has to be tailored according to that, as in sarcoidosis, serum ACE levels, calcium levels, chest X-ray, sputum smear, AFB in tuberculosis, lymph node FNAC or biopsy. Or in toxic optic neuropathies, heavy metal screening. If you suspect a ischemic optic neuropathy, to rule out giant cell arteritis and all, you have to do temporal artery biopsy. And if you suspect an atypical optic neuritis, MRI spine and anti-NMO antibodies. And also always keep in mind the differential diagnosis.
Thank you, Dr. Ann, for elaborating the cause for optic atrophy. Next, I call upon Dr. Thomas Arun Varghese for his talk on decoding the pupil. So he will elaborate how important it is to examine the pupil. We as ophthalmologists have the habit of seeing the patient after dilatation. So once we suspect neurological disease, we call the patient next day just to examine the pupil. So we'll see. Over to you, Doctor.
Thank you very much. So my next talk is decoding the pupil. So I think the size of the pupil is dependent on a balance between the ambient light, the sympathetic and the parasympathetic supply. The usual range is 3 to 4 millimeters, and you can have a physiological anisocoria, which apparently is there in about 15 to 20% of people. But a difference of more than 2 millimeters is considered significant. Sympathetic pathway, it's arising from the midbrain, going to the via the third nerve, ciliary ganglion, and then to the iris sphincter. So if you logically think, you can have a problem anywhere along this can cause a problem with the pupil reaction. And typically being the third nerve palsy, a tonic pupil, and uncal herniation. The sympathetic pathway arising from the brain, going down to the neck, and then upper chest, and then back up along the carotid artery. So you can test with the ciliospinal reflex, and the usual condition that we encounter is the Horner's syndrome. Near response is the pathway that is, as you know, is quite complex, and it is important, especially in people where you do not get a good light response. Make sure you always check a near response. Ideally, you should be checking that in every case. So history, again, just like in any neurology, neuro-ophthalmology situation, history is very important. So history of blurring, amaurosis, transient double vision, all these are going to give you clues. Headache, numbness, again suggest of demyelination. Any history of trauma or surgery. Surgery, as you know, is a controlled trauma. So history of surgery of the neck, head and neck. Anything that, any history of like whiplash, all these are going to give you possible clues as to the etiology. And systemic diseases, diabetes, thyroid, neurological problems. And it's always very important to ask for a history of previous photographs. So somebody presenting with a condition, you examine, they present say for glasses, and then you see an anisocoria. So you can always ask them to bring any old photographs, what is known as the FAT scan or family album tomogram. And that can give you a clue as to whether it is a pre-existing condition or whether it is something new. Examination, visual acuity, color vision, of examination of the lids, as you know, third nerve and Horner's, obviously looking for things like that. Proptosis, extraocular movements, visual field by confrontation. Cranial nerves, a brief neurological examination, and of course supratemporal arteries. As you know, in syringomyelia, you have involvement of the hands, so that you have a look at the hands. So all these are very important, not slightly different from your usual ophthalmology examination. And examine the neck for any scars. Examining the pupil per se, when you can gauge the size of the pupil. You can see my card is quite badly worn out. Anyway, the size of the pupil, the shape of the pupil, light reaction, near reflex, and swinging flashlight test. And important to remember, afferent pathway, an isolated afferent pathway problem does not cause an anisocoria. That is something we always need to keep in mind. So pupil, you see if it's the equal pupil size or anisocoria, and if equal, then you obviously check for an RAPD. Anisocoria, as I said, can be physiological, which can be differentiated, as I'll explain, and pathological. So it can be problem with the iris, sympathetic or parasympathetic pathway. So this you can see is a patient who had sustained a trauma. The video? Have the video, please. Video is not. Video? Okay. Anyway, here at sustained the trauma, you can see the subconjunctival hemorrhage in the right eye, and yeah. And just to illustrate the relative afferent pupillary defect, you can see the dilatation of the right eye. Okay. Next. Close. No, presentation. Thank you. So large pupil, think of a third nerve palsy, ID is pupil, or obviously can be a local cause, say post-surgery, post-trauma, and obviously think of pharmacological and systemic cause. Small pupil, you are mainly thinking of Horner's pupil, Argyll-Robertson pupil. It can be a local cause like a uveitis. So anisocoria physiological, as I said, you need to identify, you can look at previous photograph, but the reactions will be normal. That's the main difference, and usually they are asymptomatic. This is a usual algorithm that you see in textbooks. So differentiate whether it's worse in dark or worse in light, the anisocoria, because as you know, a small pupil, if it's the abnormal one, then the anisocoria is going to worsen in darkness because it does not dilate, and the reverse in the case of if the abnormal pupil is the dilated one. But the usual one that I use is this one. So first, let's see the reaction, and you can see if both pupils are reacting. So for example, this lady, 41-year-old, presented with a headache, and you can see the anisocoria left pupil is larger. So what I usually do is see the reaction is how the reactions are. Light reaction is the larger pupil, and the poor reaction, that means the larger pupil is the abnormal one. And then look for other features, any ptosis, any extraocular movement, formants, no. And then look for, examine on the slit lamp, and you can see vermiform reaction. I'll show you the video in a minute. Now video, please. Sorry. Video. First one. This is just taken with the mobile phone, and you can see the vermiform. If you observe here very closely, you can see the vermiform movements quite clearly. There you can see very nicely the vermiform movements here. So it's just taken with the mobile phone with the slit lamp adapter, and so this will save a lot of trouble. But presentation. Thank you. So as you know, presentation. Thank you. But being in Kerala, as you know, patients are highly demanding, and the patient was presented with a headache. So as you know, typically in the case of AD's pupil, you don't need to go do further imaging. But in this case, she actually had imaging done because the family were extremely worried. And MRI showed a tuft of vessels, and obviously then you have to go for further investigation. But she had the full investigation done, and everything was normal. Again, this is a third nerve palsy. You can see with but this one was a pupil sparing third nerve palsy. While the next one, this was actually a post-op lady, and she was going back after a post-op checkup on a scooter with her daughter, and then unfortunately she fell off the scooter, and you can see she had a traumatic third nerve palsy with pupil involvement here. And she made again, you go by the same algorithm. You can see the poor reaction, larger pupil is the abnormal one, but she had associated features, ptosis, abnormal extraocular movements, and yes, that was the third nerve palsy, and she fortunately recovered. So going on to the small pupils, so if the reactions are normal, then you think that the smaller one is the abnormal one, and look for the other features, and you can see slightly smaller pupil there and a mild ptosis. And this was actually a patient, he is actually a karate instructor, and then he came with some headache and some vague symptoms, and you could see the anisocoria, and he has also had a mild ptosis, and this was actually a carotid dissection causing the Horner syndrome. So Horner syndrome, I guess obviously you usually go to differentiate all these, the peripheral versus central. You're mainly concerned about the peripheral ones because these are the ones that can not just cause a visual problem but also can affect the life of the patient. So any history of neck surgery, neck trauma, also you investigate some situations. If you're really worried, you actually do an MRI, and you not just do an MRI of the brain, but you need to do an imaging right down to the neck. So that also has been included. Obviously, if it is a long-standing Horner syndrome, you get a depigmentation, and the depigmentation as well with the Horner syndrome. If that indicates that it's a long-standing and not something you need to be worried about. But it's the peripheral one that you really should be careful about, because you should not forget that we are usually used to imaging MRI brain, but in this situation you have to do MRI imaging down to the neck, and that should not be missed. Light near dissociation, mainly Argyll-Robertson's pupil, that is, you can do the smaller pupil, light reaction is absent, and near reflection reaction is present. You usually talk of the aberrant regeneration of the third nerve, which also can cause an anisocoria. This is actually a patient with a third nerve, you can see that has recovered, and when the patient is looking to the right, you actually see a meiosis. So this is one of the other features of aberrant regeneration of third nerve. You can get a synkinetic meiosis as well, in addition to the lid retraction, which you can see here quite nicely. So take home message, pupil examination should be an integral part of your examination. And if, as the chair mentioned, if you dilate the patient, just bring the patient back another day and check the pupil reactions again. And use a stepwise method. A careful history will give you important clues to the possible etiology. Thank you.
Thank you, Dr. Thomas. Next topic is Diplopia Demystified. The topic usually supposed to be done by Dr. Nina, as she is not here. Dr. Kalaimathi will cover up that topic.
Thank you, Dr. Sujitra. So, the topic is Diplopia Demystified. Diplopia is one of the commonest reasons why a patient comes to the ophthalmologist. They usually complain as double vision, sometimes blurred vision, and sometimes field defect. So what are the important questions you will ask for when a patient with diplopia come to you? Whether it is uniocular or binocular, the mode of onset, whether it is acute, subacute or chronic, whether it is horizontal, vertical or oblique, if it is constant, intermittent or variable, is it same in all gazes or more in a particular gaze, whether more for near or distant. And we have to pay attention to the associated complaints like headache, eye ache, numbness, because most of the mononeuropathies are associated with headache on the same side. And we have to pay attention to the periorbital swelling, redness, any neurological symptoms, fever, debilitating diseases, etc. Also, the history of trauma is very important, and any head injury, transient loss of consciousness, eye trauma, and etc. The superior oblique palsies usually the result as a result of a trivial trauma like falling in the bathroom, etc. And any history of ocular surgery, like even a periocular injections infiltrating into the inferior rectus can cause diplopia. And non-ocular surgeries like for example post-FES exotropia. See, you can see from this picture, this is a post-FES exotropia that was because of the inadvertent dehiscence of medial rectus, as you can see from here. And also systemic disease, ask for any diabetes mellitus, hypertension, thyroid related ophthalmopathy, malignancies, etc. So when a diplopia patient comes to you, the first question you should ask is, does the diplopia go away on covering one eye? If it persists, then you are dealing with monoocular diplopia. The monoocular diplopia means there are few conditions which could be the refractive errors, corneal pathology, lens-induced, pupillary abnormalities, retinal pathology, and a very rare condition called CNS polyopia. So as the patient enters your OP room, you have to note the look for the abnormal head posture, head tilt, any face turn, any chin up and down position, and also look for any facial asymmetry. So if there is any doubt, you have to ask for the old photographs. So you can see the head posture could be as subtle as in this picture, and it could be large as in this picture. So sensory evaluation is very important and it gives a clue about the sensory status of the patient. Ocular motility is very important. Video. Ocular motility is very important. You have to look for the duction. Look for the ductions, versions, pursuits. Look for the ductions, versions, pursuits, and saccades. Cover and alternate cover test in all 9 gazes, and also do a head tilt test, and look for any accessory signs like nystagmus. And Park's 3-step test is very important. And if you have a patient with for example, if you have a patient with right eye hypertropia, the first thing you have to do is tilt the head towards the right And if the if the hypertropia increases, then you are dealing with either right superior oblique palsy or a left inferior oblique palsy. The next thing what you are supposed to do is turn the face towards the left. And if the hypertropia increases, then it is the right superior oblique palsy. So and if on turning the face towards the right, if the hypertropia increases, then you are dealing with the left inferior oblique palsy. So this test is very important. Once you make sure about which oblique is involved, then you can settle the rectus. Prism bar cover test is very important, and it has to be done in all cases for distant as well as near. And it shows the maximum deviation in which gaze, and it also tells us about the primary deviation and the secondary deviation. Diplopia charting is very important. It tells us about whether it is uncrossed diplopia or a crossed diplopia, whether it is horizontal or vertical, and it gives us the direction of maximum separation. Double Maddox rod is very important, and in vertical deviation, the patient perceives as a parallel line, two parallel lines. In torsional deviation, they perceive as tilted lines. So we can actually quantify the torsion by asking the patient to rotate the Maddox rod. And indirect fundus examination can give a clue regarding the torsion. Forced duction test will tell us whether it is a restrictive pathology or a paralytic pathology. So at the end of the examination, we should be able to answer these questions. Is there a misalignment of eyes? And if so, is it horizontal, vertical, torsional, or a combination? Is it a congenital or acquired? Is it comitant or incomitant? If incomitant, is it paralytic or restrictive? Is there any diurnal variation? Is there any diplopia or ptosis? And is there any neurological signs? Look at this patient. This patient has bilateral and further tests should be done. These are the tests we have to do, and management depends on case-based. Management is case-based. Now coming to case number 1. This is a 28-year-old painter. He had a road traffic accident with head injury and had severe diplopia in down gaze, vision 6/6 N6. He had a right head tilt, chin down, and right face turn. This is the 9-gaze photo. He had left eye hypertropia. In this you can see he had left eye hypertropia, but in this picture he is fixing with the left eye. So it appears that the right eye is hypotropic. On left gaze, the left eye hypertropia is decreasing, and in left head tilt it is increasing. So what are we dealing with? This is the diplopia charting. We are dealing with left superior oblique palsy. So imaging was done and DMR was done. It showed 10-degree extortion, and Fresnel prism trial was given, which was not satisfactory. So left eye inferior oblique recession and right eye inferior rectus recession was done, and the diplopia he was relieved of diplopia. This is case number 2. 50-year-old priest. He had diplopia since 15 days and left-sided headache, and he was a hypertensive. And this is the 9-gaze picture. He had nothing much in the primary gaze, but he had a subtle left esotropia, which worsens on left gaze, and he had a mild hypertropia which worsens on down gaze. So from here we can make out that we are not dealing with a mononeuropathy. So imaging was done, diplopia charting, and imaging was done. Imaging showed the left paracellular meningioma with cavernous sinus invasion involving 6th and partial third nerve palsy. So this is case number 3, 13-year-old schoolgirl who complained of diplopia and blurring of vision in the left eye, left-sided severe headache, and fever 2 weeks duration, and RAPD left eye. So this is the left for 9 gaze photos. He had a subtle left eye esotropia which worsens in the left eye, and on right gaze it became exotropia. And she also had left hypertropia which worsened on down gaze, and hypotropia which was when in up gaze it became hypotropia. So here we are dealing with second, third and sixth nerve. So where is the lesion? The lesion is in the orbital apex. If second nerve is involved, it is in the orbital apex. This is the diplopia charting, and this is the picture we got. We assumed it to be inflammatory, so in IV methylprednisolone was given for 3 days and along with antibiotics, and followed by oral steroids. This is case number 4. This was a 24-year-old metro site supervisor, diplopia since 4 days. He had RTA 4 months back, CT orbit was done then, and there was fractured roof, medial wall and maxillary sinus in the right side, but he never had diplopia at that time, but the diplopia started only 4 days recently. He had limitation of the abduction in the right eye. So we thought it could be traumatic 6th nerve. But on imaging we found what is this? This is dilatation of the superior ophthalmic vein. This is a sign of corticocavernous fistula. So this is a traumatic corticocavernous fistula. So he was sent to a neurosurgeon, and transverse coiling and squid embolization was done, and he is doing well. So it could be also a sensory exotropia. This person had a trauma, he underwent surgery, and he was never given a correction. Later on somebody gave a correction and he started developing diplopia. So he was now put on Fresnel prism, and if he fuses well, he will be taken up for surgery. And it can be decompensated IDS. Now Fresnel prisms were given, and if he fuses well, he will be taken up for surgery. So systematic evaluation of diplopia is needed to decode it. Thank you.
Thank you, Dr. Kalai, dealing with that very complicated situation of diplopia. Our last speaker is Dr. Sujitra. Sujitra is a senior consultant at Amrita Eye Institute, Cochin, and with special interest in neuro-ophthalmology. She is going to speak to us on visual fields in neuro-ophthalmology. As you know, of the test of optic nerve function, visual field testing has a very important role, and she is going to speak on that. Over to you, Dr. Sujitra.
Thank you, Dr. Thomas. So we're coming to visual field defects in neuro-ophthalmology. So when to do field test? So when the patient complaining of defective vision, and when we examine, when there is no obvious ocular cause for defective vision, then we do visual fields. And also sometimes the patient itself say that there is some visual field loss. Okay. So visual field examination is important to localize and identify the disease affecting the visual pathway, and also to monitor the disease, whether it is improving or worsening. So visual field and retina are related opposite. The nasal retina represents temporal field, and the temporal retina represents the nasal field with respect to fovea. So normal visual field extends 60 degrees superiorly and nasally, and inferiorly the field extends to 70 to 75 degrees, and temporally the field extends to 100 to 110 degrees. And physiological blind spot corresponds to optic disc, and it is located 15 degrees temporal to fovea. So technique to evaluate visual field, the automatic visual static perimetry is usually done. We can do either 10-2, 24 or 30-2, and we should take only the reliable field. So when the fixation loss is less than 20% and false positive or false negative response less than 30%, we take that field as reliable. Okay. As explained by the previous speaker, the retina and optic nerve disease can have field defect, and usually the optic nerve and the retinal disease respect the horizontal meridian. As you can see here, quadrant enopia, central scotoma, ring scotoma, and arcuate scotoma, and hemifield defect. In optic neuritis, you can get central scotoma or centrocecal scotoma or paracentral scotoma. And in papilledema, early papilledema, the field is usually normal. When there is, when the papilledema is chronic, we can get either enlargement of blind spot or constriction of visual field. As you can see here, there is constriction of visual field. That is an indication for intervention, acute intervention to prevent visual loss or optic atrophy. In AION, we get altitudinal field defect. So bitemporal hemianopia we get in chiasmal lesion, and pituitary tumor and craniopharyngioma is the common tumor which causes bitemporal hemianopia due to the involvement of crossing nasal fibers at the chiasma. So here you can see pituitary adenoma causing bitemporal hemianopia initially. When the disease progresses, the field defect involving the nasal side. Craniopharyngioma causing bitemporal hemianopia. As the disease, here you can see the progression of disease and involving the nasal field inferiorly. So in retrochiasmal visual pathway, when there is lesion in the retrochiasmal area, you get contralateral homonymous hemianopia. When the hemianopia is incomplete, it helps in localizing the lesion. When it is complete, then we can say the lesion is anywhere from the optic tract to occipital lobe. So coming to optic tract lesion, so optic tract lesion causes contralateral homonymous hemianopia, RAPD, and both atrophy of the optic nerve in the contralateral side. And in the ipsilateral side, you get temporal pallor of the optic nerve. So coming to lateral geniculate body lesion, it is very rare. So here again you get homonymous hemianopia, and when the lesion is very localized, when there is involvement of anterior choroidal artery ischemia or posterior choroidal artery ischemia alone, we get homonymous sectoral anopia, and it is very, very, very rare. And coming to optic radiation lesion, here the postsynaptic fibers from the lateral geniculate nucleus are involved. So inferior fibers passes through temporal lobe and superior fibers passes through parietal lobe. So the field defect also differs accordingly. So temporal lobe lesion, we get superior homonymous hemianopia. Usually it is incongruent. So parietal lobe lesion causes inferior homonymous hemianopia, usually called as pie in the floor appearance. So coming to occipital lobe lesion, here again we get contralateral homonymous hemianopia. The characteristic feature of occipital lobe lesion here is the field defect is congruent, as the nerve fibers, the corresponding retinal nerve fibers are very close to each other. We get congruent field defect. So when we get congruent field defect, we should think of more posterior lesion. So tip of the occipital lobe, sometimes we can get central homonymous fields are represented there. So we get central homonymous field defect, and here the blood supply is dual. Both the posterior cerebral artery and the middle cerebral artery supplies here. So occlusion of PCA, that is posterior cerebral artery, can result in homonymous field defect with sparing of macula. So here we can see the homonymous hemianopia with sparing of macular central field. So lesion of the tip of the occipital lobe can be due to ischemic or space occupying lesion. So we can get small homonymous scotomatous defect if there is inadequate collateral circulation. So here again you can see right homonymous scotomatous defect due to ischemia. So bilateral lesion in the retrochiasmal pathway causes decrease in visual acuity, and the visual defect is usually symmetrical in both eyes. So when to do 10-2, when the field defect involves up to fixation, it is better to do 10-2 to examine the field in detail. Okay, here we can see that field defect involving up to the fixation, and 10-2 field showing the field defect is more in the left eye than in the right eye. So this is the flow chart depicting the how to we come to a diagnosis seeing the visual field defect. So when the field respects the horizontal meridian, the field defect is usually due to retinal or optic nerve pathology. When it respects vertical meridian, it is due to chiasma, from chiasma to posterior lesion. Okay, coming to one important field defect which I come across, I'll share this with you. This is a 34-year-old lady, and her main complaint is difficulty in locating a small moving object. On examination, her visual acuity is 6/6 and by 6. Color vision was normal, fundus was normal, and field examination showed central scotoma, both eyes, and it is repeatable and reliable. And field defect was involving central 20 degrees, but her vision is 6/6 and N6. So then we did 10-2, so which showed that field defect sparing central 10 degrees. So possibly it is due to ischemia of temporal branch of posterior cerebral artery which caused this problem. And she gave history of severe headache before this episode, possibly due to migraine causing ischemia, bilateral ischemia. So another case, she is a case of optic nerve glioma. She is under follow-up from a long period, from 4 or 6 years back. So initially her vision was 6/60 and she had mild proptosis and RAPD and mild temporal pallor of the optic disc, and you can see the visual field. Then after 5 years, when she reported to us, her visual acuity improved to 6/9 and there is 1 millimeter decrease in proptosis, but the fundus disc pallor was persisting, and definitely there is improvement in field defect. So there is spontaneous resolution of optic nerve glioma, it is being reported. So visual field defect helps in localizing the site of lesion, and also when we follow them regularly we can assess the disease whether it is improving or worsening. Thank you.
Thank you, Dr. Sujitra. We can take questions.
If no further questions, we can wind up the sessions. Thank you very much.
Thank you.